Okay, we are starting part 3 of SBF or AVF, whatever, threshold testing strategies. So let's move forward. So basically, while the testing strategy consumes more time, but why we will do? We will take appropriate threshold technique strategy because they provide detailed quantitative information to find out the threshold at each selected point of the retina, isn't it? We have discussed about how we select the point, like 30 dash to 24 dash to 10 dash to and all these things, like 10 dash to 68 points, 24 dash to 54 points, 30 dash to 76 points, and how these points, each point, we select the test threshold of each point, isn't it? So threshold testing strategies. So basically, there are two categories. One is old strategy and another is new strategy. So basically, the old strategies are supra threshold strategy and full threshold strategy. But new techniques, there is fast pack, SITA standard, SITA fast, and basically you have to understand this. It's very famous in MCQs. What SITA stands for? It stands for Swedish Interactive Threshold Algorithm. Okay, so SITA standard and SITA fast you see a lot of time in your clinical practice, and fastback very less, and old strategy extremely rare. But yes, we use it in case like tenders 2 and macular programs and all. Okay, so super threshold is time saving because we always put light in super threshold range. So screening for the response of defect, presence of defect, and roughly localizing screening strategy. So basically, super threshold is always used as a screening strategy, not other things. Okay, so two type of super threshold: single intensity and gradient adaptation. Single intensity means static super threshold strategy, one level super threshold strategy. You put one level super threshold strategy only. Then gradient adapted threshold strategy means two level super threshold strategy. So basically what it means is actually one level suprathreshold is a stimulus that is 2 to 6 decibel brighter, that is definitely suprathreshold. Then the expected heal of the vision is used for the test and multiple location of the vision. So basically we kind of have rough idea of hill of vision, isn't it? And every point we put around 2 to 6 decibel higher, brighter uh, stimulus to examine the visual field. If there is any sharp depression, then we will find out any adjustments for the screening, isn't it? And another two level means what? Stimulus luminance is automatically modified to the brighter at the more periphery location and dimmer centrally. Thus, the suprathreshold level will be taken into account in the normal shape of vision. So, in two, gradient adaptation means the brighter stimulus is thrown in the periphery of the retina. The sharper dollar is stimulus is thrown in the center of the retina, so that we adjust, we do gradient adaptation from center to periphery. That's the concept. But in both cases, we always project suprathreshold. So full threshold and normal strategy. Full threshold is used today also, but not in regular screening, but sometimes yes. So basically, full threshold means the good old 4-2 bracketing strategy. That is staircase method. So differential light sensitivity determined by using 4-2 bracketing strategy, which is also known as staircase method. So computer determines the threshold at first at a point, primary point per quadrant, that's 9 degree away from the vertical and the horizontal meridian in 30-2. So primarily we find their first thing, and then staircase consists of 4 decibel decrease in light intensity until the patient fail to respond first. Then we reverse 2 decibel increment until the patient can see the light again. Second reversal. Then final level of the sensitivity is recorded. So it basically means first light projected in suprathreshold region, then we reduce by 4 decibel, it's again seen, and reduce 4 decibel, it's not seen here, isn't it? So seeing area and non-seeing area. So basically, and now you uplift by 2 decibel, and again you uplift by 2 decibel, then it's seen and it is recorded as threshold. So basically, it's like stacker, isn't it? Reduce and reduce, again increase by 2 increase. Yes, it's seen. So basically reduce by 4 decibel, and whenever it's not seen, then you increase by 2 decibel, and at the first point of seeing, then you take it as a threshold. So fastback, what is fastback? Its name itself, isn't it? Fast. So it's basically uses 3 decibel steps. See, staircase terminates when it crosses threshold, means first threshold is recorded at the last seeing stimulus. It sings, so suppose example this point is sing, you reduce by 3 decibel, and again sing, you reduce by 3 decibel. Now it's unseen, last seen point is recorded as a threshold. Finished. It's just reduce and reduce and reduce. Then whenever it's not seen, the last seen point is taken as a threshold. Finished. So time saving, one third of the time of full study. It's very fast. That's why its name is fastback, because time is saving. Drawback, short term fluctuation more and increase threshold error, and thus reducing the reproducibility. The main is reducing reproducibility. It's basically you do one time and you do another time, there is high chance of getting different value. Okay. So comparison between the standard full threshold and the fastback is basically, what is the comparison? See, full threshold is this, isn't good old 4-2 bracketing technique. It reduces first 4 decibel, then again 4 decibel. If non-seen, then it's increased 2 decibel and increased 2 decibel. But in case of fastback, you only go reducing 3 decibel, reduce seen, then again reduce 3 decibel. It's non-seen. Then last time which seen, this point we take as a threshold. Okay, that's simple. So SITA, which is very very common, and you will see a lot of them. What is SITA? SITA. So basically, what is SITA? Swedish Interactive Threshold Algorithm. The ideal threshold algorithm estimated the threshold with a high precision with minimum time. That's the beauty of this strategy. Precision goes high, time goes lower. Also uses the Staircase method to determine the threshold like standard threshold. So it also uses the Staircase method, but it compares the threshold of the patient with the recorded normal and abnormal value and makes sophisticated statistical analysis and give probability of the plate. So it's very important that it compares the threshold of the patient with the recorded normal and the abnormal value, recorded abnormal, normal, and abnormal value, and makes sophisticated statistical analysis and give probability plotting. And that's why it's very important that SITA is very much you would be seeing in your clinical practices in optometry. Okay, just remember this point. Why SITA is best. So, unlike other threshold algorithms used in perimetry, SITA adapts to stimulus presented speed to reaction time of the patient, which most cases reduces time. Since if patient is just going one fast and fast, just responding fast, then it will present speedily stimulus too. But if patient goes slow, then it will also go slow. So that's why there is a chance of making time adjustment. So available in two form, what is SITA standard and SITA fast. So I don't have to tell you why they are different. Definitely fast means it is faster. The difference between the two is the chosen level of accuracy and threshold estimation. It's very important. If it goes fast, then accuracy will little bit goes from our hand. So SITA fast is more faster and less accurate than SITA standard. As I think I don't have to explain why it is a standard and why it is SITA fast. So comparison of the SITA algorithm with other threshold strategy in accuracy. So SITA standard is equivalent to full standard threshold, consuming less time, because full standard threshold consuming more time, but SITA standard is in accuracy it's moreover equal to SITA standard is moreover equal to standard threshold. At the same time, SITA fast is equivalent to fastback, consuming less time. Even more, it takes SITA fast takes less time than fastback. Okay. So in this picture, again I have taken this picture from Ready GR. So you see the time taken. So this axis is time. See 24-2 SITA fast takes approximately 5 to 6 minutes, isn't it? Whereas 24-2 SITA standard takes approximately 8 to 9 minutes. See, 24-2 fastback is equals to 30-2 SITA standard, which takes approximately 10-12 minutes. but 30 dash to full pack and 24 dash to threshold takes approximately around 14-15 minutes. See, 30 dash to full standard, it takes a lot of time, like 20 minutes, isn't it? So that's the gross idea. So, see the testing strategy, the comparison. See, yeah, it's very important. 30 dash 2, 24 dash 2, 10 dash 2, macular program, nasal step. First, I want to tell you, macular program and nasal step is not in the SITA. SITA, there is no SITA for macular program. Both SITA standard, SITA fast testing studies are not available in macular program and nasal step finding. There is no. Okay, first. So then 30-2 and 24-2, it's very likely there is SITA standard and SITA 5. 24-2 is standard and fast. In 10-2, there is SITA standard and SITA fast. Okay. At the same time, fast pack, there is also this all the strategy. In fast pack full standard, then in macular program you have macular full threshold, nasal full threshold, macular fast pack, and nasal fast pack. Okay, these are the things you will have in your Humphrey. So, what is this? In general, full threshold and fast pack strategy are not used now. You just remember this. And SITA standard and SITA fast strategy are being used in most cases. That's very SITA is very important. Full threshold and fast pack strategy will be used for the parameters which do not have normative data. Normative data by what? Normative data by SITA. If there is no normative data in SITA, for example, macular program, then you will have to use full threshold fast pack. So SITA strategy are not available for the parameters which have normal data. The normative data not available for the test that conducted with the following parameters, like macular program, there is no normal data. Nasal step, no normal data. Point pattern in the fall all customers, and for all the tests conducted in size 5, because in we use standard size 3, isn't it? If you use size 5, Goldman size 5, then there is no normal data in case of SITA. So full strategy or fast pack strategy will be used in such a parameter if there is 5 size is used, or if there is macular program or nasal steps. In this particular case, full threshold and fast pack be used. Okay, so let's discuss how to think. So this is again from GR Reddy, that summary of selection pattern. See, selection of the point pattern according to the clinical stage of glaucoma. If there is advanced glaucoma, you don't think about 30-2, 24-2, you directly go to 10-2 point. Or if there is glaucoma suspect or estimated glaucoma, then you suspect, then you will take 24-2, and sometimes people take 30-2 also. So, but don't, we will definitely delve into it in next slide why 24-2 is we choice in our case. But yes, 30-2 is also can be done. But if you do 24-2, then it happens any point on the inner most circle has 0 decibel. Means 0 decibel means what? Absolute scotoma. Then you have to move to 10-2, because 10-2 means 20-degree visual field. In that particular case, is very important. Now see, you did all the things, then this happen. If the field is so advanced that most point is sensitive is less than 10 to 15 decibel, if macula is split is present, then selection you have to go to this. See, 10 to central field with 5 size stimulus, macular program with 5 size stimulus, custom test with 5 size stimulus, and we know that if you do 5 size stimulus, there is no SITA normal value. So then these two probabilities there. If there is no split in the macular progress after the surgery, and presence of the split macula potentially risk factor for the filtering surgery. See, again I came to this. Okay, the selection of the test detect glaucoma field defect in a tabular form. So you suspect glaucoma, then there is two things you can do: 30-2 SITA standard or 24-2 SITA standard. We will definitely discuss between these two why we can choose 24-2. Okay, but let's just think, whenever you suspect something, 30-2 is a better idea, but you can also do 24-2. If there is an established glaucoma, see, you don't suspect here, you have already diagnosed that's glaucoma, then 24-2 SITA standard will be great idea, because now you have only one thing to do is you have differentiate whether there is a progression or not, and then 24-2 would be far than, more than sufficient, and you come to the conclusion that it's advanced glaucoma. At that time, 20-2 SITA standard or 20-2 SITA fast would be better. And if you move again deeper, advanced glaucoma, macular program definitely full threshold. So above all, test can be conducted with the stimulus of 5. It's very important. Stimulus size can be changed, because in Humphrey, I think from 3 to 5 you have stimulus size 3, 4, 5. So if there is elderly patient and not able to concentrate for the longer time, then this is gold. Just remember, this is gold, because it's 24-2 SITA, but at the same time fast. That's why it will take 5 to 7 minutes. So whenever patient cannot concentrate for the long time, 24-2 SITA fast is a gold. It will save you a lot of time. Okay. So now that's the point I want to discuss with you, because it's very important. Okay. 24-2 point pattern is the test of choice, even with a suspected case. I have told you in this, if you suspect something, there are two probability: 30-2 SITA standard and 24-2 SITA standard. But we say in this slide that we are saying 24-2 point pattern is the test of choice, even in the suspect. If you are diagnosed someone, 24-2 is very much comfortable, and we are definitely going to do 24-2. What if you suspect only, then you can do 24-2. Why? It is general concept that uh, that we should select 30-2 pattern in the glaucoma suspect, but not we can do 24-2. There is 5 points. Okay, the first point is the outer set point of 30-2 are not considered while selecting seventh best point, sensitive point, when we are plotting total deviation numeric plot. So basically it's very important. Seventh point, we will definitely discuss on the seventh point, why 7 point. Okay, but just let it be that 30-2 has outer circle, it is not considered in the seventh point. Just remember that. The outer set of the point of 30-2 is not included in the fight zone of glaucoma hemifield test. So basically, outer zone of 30-2 is not included in glaucoma hemifield test. Then definitely 24-2 area is sufficient for glaucoma hemifield test. Third reason is the outer set of 30-2 are not considered in Anderson's criteria to pick early defect, because Anderson's criteria is the gold, isn't it, till today? So outer set of point in 30-2 are not critical for Anderson's criteria. It's very important. And again, fourth, the outer set of 30-2 are tested last. The patient may get fatigue, and there are chances to get high fixation loss and high false negative error. That's why 24-2 may be a better. I don't know, but there is an argument. The average normative data value of the peripheral points have wide range. So taken all that point into consideration, 24-2 point pattern becomes a choice for even glaucoma suspect. That's why we think 24-2 can be a first starting point. Okay, so with that we finish today's presentation. This is gold. Just pick that book and read. Okay, fine, this is very good and this is very good. Okay, this done. Choose.